Fernandas, you decide when you start.
7 horas, então, em ponto.
7 horas em ponto. Pode dar um minuto. Eu estou entrando aqui na
Você que vai falar,
penumbra.
Fernanda, eu vou ficar quietinha até a metade, até ele terminar, então, tá?
Então, boa noite. É um enorme prazer que a gente tem uma aula hoje do Dr. Ralph Ziegler. Eu só queria lembrar que a gente tem tradução simultânea. Então, é só clicar no ícone abaixo. E as perguntas vão ser feitas pelo ícone também de perguntas. Vocês podem perguntar durante a aula, mas serão respondidas no final da aula. O Dr. Ralph Ziegler, ele é médico pediatra em Münster, na Alemanha, pioneiro no uso de bombas de insulina para o tratamento de crianças, professor da Wilhelms University de Münster, presidente do Grupo de Trabalho Alemão para Diabetes Pediátrico, consultor de diabetologia pediátrica para o Children's Hospital of San Francisco em 2005. É uma honra tê-lo conosco. Muito obrigada. Quando o senhor quiser, pode começar a aula.
Okay, well, thank you very much for having me at your web meeting. And as I heard, you are such an active group and society, so it's a real honor to be here. For us here in Germany, it's already midnight, so we already had our day. But I'm still very anxious to join you here and to share with you the views on diabetes, and here diabetes technology, and one certain part of diabetes technology, which is CGM, and how to use CGM and how to use in this continuous glucose monitoring, especially those trend errors which we have. So this was the topic I was asked to refer here. And so I would change now and share my presentation. And as I understand, after that, we will have some Q&A session and question and discussions. And I would be really more than welcome or more than happy to discuss any questions and criticism and whatever you feel like after the presentation. So I would change now, and let's see. Okay. So I hope you can see everything, and it's working. At least it worked when.
Yes.
Okay, thank you.
We can see.
Okay, so we got the okay. Well, so the topic of my presentation is how to interpret trend errors on the real-time CGM or on this intermittent CGM, and what to do with it, and especially how to help our patients to actually use it. So these are my disclosures. And just to start right away, it's always the question or the argument in diabetes with the insulin. What is more important, bolus or basal? So the short-acting insulin or the long-acting insulin, and what accounts for the actual result and for the patients. And I believe, as a lot of other diabetologists, that the importance of the right bolus in insulin therapy is the main cause of, especially of course in type 1 diabetes patients. And why? Well, we strive for that the bolus should account for about 60 to 70% of the total daily dose of insulin in type 1 diabetics. So just to look at this, the amount of insulin which is given with bolus is of course much more than basal insulin. And most of the glycemic variability in our patients comes from the bolus or the time around it and what happens around when giving a bolus. So the meals, sports, or any other things which is encountering during the day. And I think everybody who takes care of the patients with diabetes and looks at CGM curves and these are two examples, you can see that the most variability is coming from the time around boluses or of the bolus himself. And for example, in this one here, you see this uprise. Well, and this is the bolus. So what happened here? The bolus came a little bit too late because it was given when the glucose was already high instead of maybe up front. Here it worked okay. Well, here it was maybe too little, and we see the rise here. Here again, but now after the bolus, it's a low, and it's a hypo after the bolus, after this one here. So you see only of this, in this one day, there are at least 2 or 3 or 4 incidences where the amount or the way the bolus was given is actually being reflected by the glucose level. And at this example below here, you can see the same thing. This is just another curve, and I think everybody knows it, this up and down, and especially when you take care of kids or adolescents with diabetes, this is what we see every day and every day. And you always ask, well, what happened here, what happened there, and so on. And it's mostly the answer is, well, somehow the bolus didn't work. And it is a tough thing to do because the major task for our patients, and in my case for the kids and for the adolescents, because I am a pediatric diabetologist, it is the intellectual task of using and calculating the right bolus, the right insulin dose for the meals or for the other instances. And it is not so easy. And I'm also a great advocate of a bolus calculator because the patients have to check how much and what kind of food do I eat. So it's not only carbohydrate counting, but we would be happy if they at least do that. Then what is a carbohydrate factor at this time? What or how much should I correct for which glucose level? And to which target range should I correct? So these are already 4 single things you have to take into account when you calculate your bolus. And then also in different situations. And then every day at every meal. So this is a major task. And then again, here comes hypoglycemia. And we all know that the fear of hypoglycemia is really the worst for our patients and the families. And it has been said that hypoglycemia, or the fear of hypoglycemia, is much more powerful than the fear of hyperglycemia. And when you sit in your counseling the patients, the parents or the caretakers, they might have fear of hyperglycemia when they look in the long term, but the patients themselves, the kids and the parents of the young kids, they have always a very large and really a burden of fear for hypoglycemia. So to look for ways to reduce hypoglycemia and also hyperglycemia is really what we all strive for, and we have to find the right way to do so for our patients. What do some then just, as one way to reduce hypoglycemia? Well, they don't give a bolus at all. Sometimes that's a reason. With our adolescents, very often it's the reason, oh, well, I didn't think about it or so, and I missed it. Well, if you miss a bolus, first of all, it is very often, 65% miss the bolus, at least one bolus per week. I mean, this is really very common and very realistic. But if you look at this chart here, you see that just if you miss 2 boluses or 4 boluses per week, the A1C rises in a very stringent way. And this is just for 1 or 2 or 3 boluses per week. Another study showed that nearly 40% missed more than 15% of the bolus on the previous day. And there the difference was between 7.8 and 7.0 on the A1C. So missing boluses, let it be for just missing it or omitting it because they don't know what to do or because they have fear of a hypo, is really one topic we have to look at, and we have to minimize whatever we can. And by the way, this is not only for my beloved adolescents, but it's during the whole age gradient. And here even, you know, the young adults, if you can call them, till 35, it's nearly 1/3 of the patients miss boluses or skip boluses during the day, and you see how it goes down. But it's still, even in the quote older patients, it's nearly 1/5 of the patient who miss boluses. So this is a big topic. And here's another from Thomas Danne. He plotted also, it's a little bit different way, but it also shows how important the right bolus is. If you see how many boluses you actually give, the more you give, the better the A1C is going to get. So this is just, I wanted to show you the bolus. It is very important in our patients with type 1 diabetes, and we have to find the way to get the right calculation. Now, CGM came into place, and we all said, well, this is so great. And with CGM now, it can be used by everybody. It's so easy. Just look at the screen. You have all the information, and it should be, or should get so much better. And it's faster. It is more like a video and not like a snapshot. So you do have more information. And yes, it is right. You do have much more information. But, well, what do you do when you look at this? You do have the information, but, well, what do you do with it? It is so much better than before. And we have to help our patients, and we can't let them alone. So, well, just do it. That's probably not the right way to say it, but we have to help them and to show them how should they do it and what should they do. There are now a couple of studies out, or papers out, on what are the barriers or the reasons to discontinue CGM, because CGM is not it's not only a good thing, a great thing, but it's also it has its barriers. And just to show you here, two things are, I'm too busy to learn how to use a new technology, and I do not understand what to do with the information or the features of the device. So, as I call it, just giving the box with the new device and say, well, this is great, just use it and everything is going to get better. Well, this is definitely not the way to do so. So we have developed some teaching material in Germany where we actually show how to use CGM, and it's in 5 modules and in 5 parts of the course. And I just want to show you here with the trend errors what can happen. So, or what is the difference? Here everything is fine and it's going to be stable. Here it's going down and here it's going up. And this is then also, here it's only going down, but at totally different levels. So how do we teach, or how can we give an advice to our patients what to do with this information? We have to go a little bit into what it really means, and the patients do understand it, because we have to tell them what is the time frame of the change, and this is about 15 to 30 minutes. So whenever you have an arrow, it means what happens in about 10 to 15 to 30 minutes with the glucose level. Is it stable, going up, or going down? And this is important because usually the acting time of insulin, of the main acting, of insulin, also the fast one, it's also about 15 to 30 minutes. So it's about the same time frame. And what would happen? Well, if it's the normal insulin dose and you have a no change error, of course, you're going to stay stable. If it's going up and you don't use the error, you probably give a too small amount of insulin, and then the glucose level rises. The other way around, if the error is going down and you don't account for it, and you give the amount of insulin you would usually give, it's probably going to be too large, and then you have at least the chance or the risk to go into hypo. So the basis of therapy adjustment for our bolus are a couple of things. Of course, you always look at the current glucose level, the target range, where do you want to get to, then the carb-insulin ratio, and then the correction factor or the insulin sensitivity. And now with the new information of the CGM systems, you have the trend error information. So at all these 5 parts, the patients have to look at. Well, how is the trend error information used in general? And as you see here, there are a lot of different systems, and they usually work pretty much the same. But if you look at it into more detail, it is not really the same. So the reactions for those errors from the patients is usually actually gut feeling. So just, by rule of thumb, or, well, I feel like this. Either I eat extra carbs if the arrows are pointing downwards, or I give a little bit more, or I give a little bit less, or I adjust my basal rate with an insulin pump. So there are so many options to do, but very few patients and also teams really know what to do when the arrows are pointing down or pointing up. What is another problem with the trend errors? We have different errors for different systems. So as you all know, we have Medtronic, we have Abbott, we have Dexcom, and they have one arrow up or 2 arrows up, one down, one straight parallel, and so on. And I'm going to show you. So there are different errors at different systems. And it's also a different definition on when does the system show an arrow up or an arrow down. And we don't have any standardization in clinical use. As I just said, only very few teams have good guidelines what to do or what to advise the patients. And this is an overview we put together a year ago or so for the different systems up here. What does it mean for the different errors? And here you see right away, well, not every system has every arrow. So you have to see which system you are using. And even if you go, for example, this one arrow up, it is a different definition. How much does the glucose rise in which time, usually it's per minute, to give you this error? So this is above 2 milligrams per minute. This is 2 to 3 in the Dexcom, 1 to 2 only in the Medtronic, and again in the Eversense by Sensonic, again with more than 2. So this is pretty close, but it's still not the same. Well, we said the most important thing is what is anticipated glucose change in about 15 to 30 minutes, and we looked at 30 minutes and just kind of translated or calculated the amount of change to the glucose range, which we will expect after 30 minutes. And look again for this one arrow, it's going to rise more than 60 milligrams per deciliter in 30 minutes. Well, with Dexcom, it can be between 60 and 90, but in Medtronic, only 30 to 60. So there is a range, and whenever you talk to your patient, at least you as a team or as a doctor, you should know that there is a difference. And this makes it much more complicated, or at least you have to think about when you give recommendations. Okay, so we said, well, we do have to get some kind of guideline or a statement or at least some advice for us, for our teams. And we looked at what has been published previously for those therapy adjustments. And as you can see here, there are a couple of publications out. It's a little bit maybe hard to read, don't worry. It is being published. And also I just highlight here to explain the differences between those two different recommendations. Look at 2 arrows up. So the first one was, excuse me, from JDIF in the US, and they said, well, just increase the total dose for this bolus by 20%. Then China, they said, well, no, you should calculate your level of glucose, adding it up by 50 milligram per deciliter, and then use that number of your glucose level and correct with your correction factor. So you add an absolute value. Then the next recommendation was by Petrus and Edelman, and they said, well, 50 milligram per deciliter to add is not enough. You should add or calculate 100 milligram on top and then use your correction factor. Well, this is, of course, very much mathematically, and Klonov then said, well, make it really easy. If you have 2 levels up or 2 arrows up, just add 2 units of insulin, independent of what the amount of bolus of insulin was at that time. So what I think is a big problem, these are prone to calculation errors, and this is too simple. Then Laurie Lafell and Garcia Aleppo, they did it a little bit different. They differentiated first between adults here and children here, and they adjusted for the different insulin sensitivity. So if you have a low sensitivity and here a high sensitivity and children an even higher sensitivity, you should add or subtract, depending on the error, a certain amount of insulin. But depending what is your insulin sensitivity. And we all thought, our group, that this makes a lot of sense because it is, as we all know, different in which kind of sensitivity you are, how much you should correct or not. So this is, you add a correction by the absolute units, but regarding to the insulin sensitivity and age, adults and children. Okay, now what is the German experience, or what was or is the recommendation of the German group? We said, yes, this sounds already pretty good, but we would like to go 2 steps further. One step is that we use scorecards for children and adolescents, also for type 1, I'm going to show you adults, and also for patients with type 2, using insulin, of course, in type 2. This was one thing, and I'm going to explain just in a second why we think this is so important. And then we also discussed quite a bit that looking at the insulin sensitivity is probably not enough, but you also have to look at the level where the glucose level is right now, because it is a difference if you use it from, or if you correct with your bolus, if you are between 70 and 180, which would be the range where we want to be, as we all know, with a time in range, which is defined by 70 to 180. Or if you are up to 180 to 250, or if you are even upper or even higher with above 250. So we used different levels of glucose and then also the different correction factors in each of those categories. And then we came up with these additions or subtractions depending on where the arrows point to, and we differentiated it also to the different manufacturers or different systems. This looks a little bit complicated, but as I'm going to show you, it's really easy to use for the patients. So this is what I just said. These are now what we call the scorecards. This is now for the patients with type 1 diabetes, and it's color coded, but this is more just a kind of a gadget. So this really doesn't make so much difference. Here is for type 2. And what the change is, or one big change is the insulin sensitivity. As I can go back here, you see this is insulin sensitivity for type 1s, below 25 milligrams and so on, up to above 75. This sensitivity, insulin sensitivity, is nearly never been seen in patients with type 2. So if they are really insulin sensitive, that's up to 50 milligrams per deciliter per unit. But then they are so little insulin sensitive that it's below 10 milligram per deciliter per unit. So they really need a lot of insulin. So that's the reason we differentiated not only into adults and children, but within the group of adults between type 1 and type 2 needing insulin. And then, of course, we have our children. And with the children, we know, or we learned, and at least the participants who are pediatric diabetologists, that sometimes we have to change it only a very little bit. So that's the reason we have, and well, it's right on the side here where we have now our pictures. Or here it is sometimes with only a quarter unit, you see quite an effect. So we went down to really small fractions of insulin to use as an advice. So how does it actually work? Here it is an example, and I have, wait a second, here's this example. So we use it for children and adolescents, for example. The level is 210. You have a correction factor of 60 and 2 arrows up. Then you just look, where is your glucose level? Well, with 210, it is between 180 and 250. And then we said the correction factor is 60, so it's between 50 and 75, which comes, if you are here at 2 arrows up, you should add 1 unit of insulin to the bolus you calculated, for example, for your meal. So it is, yes, you do have to go through a couple of steps, but you don't have to calculate. And this was something we wanted. We didn't want to put the burden on the parents or on the patient to actually calculate a percentage or something, but just look it up in a certain way. And this is kind of a summary. If you say, well, this whole scorecard, you would say, well, how should a patient actually use it? And how should he know where to use it? But we found a way, and I'm going to show you in a second, how to translate it in a patient format. So this is what we call the so-called easy wheels. Probably some of you might know this. This is for a lot of different things being used. We call it, or we use it, we know it for body mass index and so on, or other dosage calculators. So you have here the different glucose ranges on the outer wheel, and here you have the errors up and down for the different systems. And then if you turn it around, here the numbers, you can't see it because this is still the dummy before we actually produced it. And then here comes up how much you should add or subtract. And this is for the different groups. So, well, this is also not necessarily for the patient, but for the patient, they get this little actually piece of paper, but there's also an online version. And this is now, the team says, okay, for you, because you have now, for example, the correction factor of 35 or whatever, for you, you should use, when you have your one up and you are between 70 and 180 or between 100 and 250, then you should half a unit or 1 unit or nothing at all if it's parallel and so on. So this is where the team is putting down the numbers at the visit of the patient, and the patient can take it with them, or as I would always say, make a picture with your iPhone or so, then at least you have it always with you, because usually the paper is going to fly away, at least in the parking lot, yeah, at the latest. So you can keep it, and you can also change it, of course, if you see it at the next time and you say, okay, now your correction factor maybe is different. So then you as a team can just put in the new numbers. And this is handy, it's easy to use for the patients, and we use it in our clinic now, of course, very intensively, and it works very, very well. So, of course, there's also some criticism. One of the biggest criticism is that we use in our tables, at least for the children and for adults with type 1, when they have a high insulin sensitivity, we advise for half units or sometimes even for a quarter units, as I showed you for the children. And the criticism is, well, you can't actually use it because you don't have an insulin pen with such small increments. You can only use it with insulin pumps. Well, this is not really right, because when you start rounding it mathematically, which you have to do if you have only 1 unit pens, for example, you can do it only at the end of the calculation. You shouldn't do it right away. So if when we would actually, prepare those scorecards, if we would already round it, we would make an error. And then in the calculation, we would make even a double error if we calculate it again. Let's show me an example. If your patient wants to eat 20 grams of carbohydrates and he has a carb factor of 2.5 units per 10 grams, then for the carbs, he should add 5 units of insulin. And then for the trend error, just wherever, like the scorecard says, well, you should add 1.5 units. So yes, it comes to an odd number, 6.5 units. Then you do have to round if you have only 1 unit pen. But it could also happen if you have 30 grams and he has the same carb factor, it comes to 7.5. And here you have to add 1.5. Well, it does come out actually in an even number. So you can't really say how often it's going to work or not. But or you have the same chance that you have an even number than you have an odd number. So that was the reason we said, well, we do want to advise the patients with a right change in the bolus for the errors, and then round at the end of the calculations, because maybe you don't even have to round to a lower or higher number. And we are doing this now all the time, as I said, and it works very well. And you can use it also with insulin pumps. So with insulin pumps, of course, it's no problem at all. And with the newer insulin pumps, and I'm aware that not every country has the newer insulin pens with half units or even decimal units now with some pens, but it will come out more and more. So we think it is the right way to go for half units or even quarter units in the scorecard, because at the end in the calculation it might even out. So then, of course, there are in other countries different advices now also. For example, in Spain, they had it similar, but we think a little bit more complicated. So it is one for prandial. This looks pretty easy, but then they have it also for different ones for insulin pumps and for MDI. And then, especially if you do sports, if you do driving, well, I personally think this is getting a little bit complicated. And for a patient to decide, okay, I am doing sport, or I did sport, now I'm going to do driving and so on. And then I have different advices. I'm not so sure if this is practicable, especially with the new CGM system. They do react so fast that the trend error is already kind of incorporating what you did. For example, exercise. Of course, they can't think ahead that you're going to drive, but this is driving and diabetes. It is special, and the patients have to look for it. So, but this is one way of doing it. Then in Portugal, they differentiated between pre and postprandial. This is one thing we don't do, because we also say with the time and range and those recommendations out now, we also don't differentiate between pre and postprandial, and there's no way really to make to give a limit when should you use what. So that was the reason we decided against it. Here they did it, but they didn't give any actual advice on what to do or what number to use, but more general advice. You know, check again, think about eating and so on. I mean, it's much more easier for you to read than for me to read. But so we would say this is a good way of teaching our patients, but it's nothing for them, you know, to give them at hand to say, okay, my value is like this, and what should I do right now? Well, what is still missing? One big thing is what we are all recommending or talking about and discussing. It is very nice, but there's no study out showing that it actually works. So there are small studies, like in a CAM, which was just published, where they used the one from Laurie Lafell, those advice, and it worked pretty well, but it's nothing in a real world setting. And it's also very hard to set up such a study, and you need a lot of patients, so a very large N, a very large number. And actually there isn't out a study, and we talked to some of the companies, and actually nobody was really so keen on doing a study without. And also this information should be incorporated into the bonus calculator, because when we on one side say, well, using a bonus calculator would be so much help for our patients, but the errors are not included, then it's only, you know, half the show. But, and this is, I think, very, very nice. I know that the Brazilian Diabetes Society is preparing a position statement for those insulin adjustments based on the trend errors. And I'm sure that they're going to incorporate all those different things and coming to a good conclusion. So yes, we do still have to work on it, but I think it's very well and wise to use. And thank you all for your attention. Thanks a lot.
Muito obrigada, Dr. Ziegler. Foi excelente a nossa aula de hoje. Nós vamos daqui a pouquinho abrir o nosso Q&A e, primeiramente, o Dr. João Lindolfo vai falar um pouquinho aqui com a gente, enquanto vocês se esquentam aí no Q&A, ok?
Muito obrigado, Dr. Ziegler. Realmente é muito inovador a sua apresentação. Muito obrigado a todos que tenham comparecido. Eu vejo que tem gente aqui de 6 estados brasileiros, além do Distrito Federal. E muito obrigado a todos que compareceram aos 8 meetings que tivemos esse ano. Talvez esse seja o nosso último web meeting do ano, depois, porque final de novembro já começamos com o Congresso Brasileiro, né? Mas, de qualquer maneira, muito obrigado pela presença de todos e devolvo a coordenação agora para as 2 Fernandas, para que as Fernandas coordenem as perguntas. Por favor, faça as perguntas no Q&A que está embaixo da tela do Zoom. Muito obrigado a todos.
Bom, eu vou aproveitar. Então, tem já uma pergunta, que é da doutora Renata Santarém. Boa noite, doutor Ziegler. Como devemos abordar as correções propostas para crianças menores de 5 anos? Quando temos menos previsibilidade quanto à sua alimentação e atividade física. Qual a sua experiência em relação a esse grupo?
So we were very cautious when we put up those scorecards for the little ones. And one way to use it for the little ones is they usually have a very high insulin sensitivity. So you move up to this part of the scorecard. And actually, you know, with eating and with exercise or movement, it's not necessarily exercise, just moving around or so, playing, it is always a big challenge. And you have to adjust for it a little bit, but there are so many other things that basically what I always teach my parents is use some kind of guideline. And if this doesn't work, well, then change this. But if you start right away and say, well, okay, maybe she's going to grandma today and she's not like this food today, and she's going to kindergarten or not to kindergarten or to the neighbors or whatever, and the sun is shining and it's raining probably in 2 hours and so on, and so I do a little bit up and a little bit down, it usually never works. So say, okay, I do usually this and this and this, and we do it. And if in 2 hours it didn't work, well, then you do have to change again. But at least you have some kind of concept or so, and some rule you're gonna follow. This might not work all the time, and especially with the little ones, we all know it's gonna change all the time. Then you have to change in a month again. But then you can, you know, also change with this, with those scorecards if you think that the insulin sensitivity is going to change, because this is usually the thing for the little kids that changes and we don't change fast enough. Or, yeah.
Mais uma
Ana,
dúvida,
posso
então?
fazer só uma pergunta para ele?
Sim.
Dr. Ziegler, boa noite. Uma dúvida, se após 2 horas da correção, o paciente continua com glicemia elevada, com a seta subindo, o senhor repete o mesmo processo, então calcula da mesma forma que você orientou?
Yes, so the recommendation is not to use it before 2 or 3 hours. It depends a little bit, and also local, some say don't give another bolus after 2 hours or after 3 hours. So you should wait this time, and then do it the same way, because, you know, if the arrow is still pointing upwards, then it is still going upwards. But we also try to teach our patients that the error for itself is not the only information. You should always look also at the curve, because as we all know, the error can go up already, yeah. Or no, it's the other way around. It's still pointing downwards, but the curve, you're already at the nadir, or you go already a little bit upwards. So the error is like kind of, you know, lagging behind a little bit. So you should look at it. But if it's going upward, well, it's going up. And actually, when we, at the very far end of those scorecards, we say, if the ketones are positive, then you should follow your ketone rule and not the scorecard. So independent where the error is going to go. If you have ketones, then you should follow the ketone rule.
Obrigada. Parabéns pela excelente apresentação.
Nós temos mais uma pergunta do Alexandre Vieira. Ele falou uma excelente aula, obrigado. Gostaria que comentasse a respeito do uso de setas em gestantes.
Well, this is always a very difficult question. But here again, I mean, the arrow is just showing us where to go. And in pregnant women using insulin, it also all depends on the insulin sensitivity. So the insulin sensitivity, I think, is the way to adjust for all those different questions. You know, if you have a high insulin sensitivity, then it is being taken care of in the in those scorecards, independent on if the patient of the person is pregnant, is young, is old, is doing this or doing that. You know, if the insulin sensitivity is like it is, then at least it's a good guessing. I mean, we know that this is not perfect, not at all. I mean, really, that's not perfect. But we would say it is an educated guess, as the Americans always say. I really like this saying, because this is the only thing we can do. We have to think about what is realistic, what is also experience. I mean, as I said, we don't have a study or so. It is a lot of just experience. But if you put all the years together, it was quite a bit of experience. And then we say, okay, this is realistic. After we did the scorecards, we actually checked, everybody in our clinic, we checked, did it work or could it work? And then we adjusted again, we met again, and we said, no, we have to change a little bit here and there. And so it is more or less an expert opinion. That's what it is. But we think it's a good way to start.
Eu tenho uma pergunta para o Dr. Ziegler. Então, em relação a exercício, atividade física, você faz alguma assim, diferença entre um exercício, por exemplo, de endurance ou um exercício de resistência, quando você indica para as crianças? Assim, qual a orientação em relação a essa interpretação das setas de tendência?
So this is really getting a little bit tricky. That's true. But here again, you can still use it as one piece of evidence or so when you calculate bolus anyway. You know, you have to take into account all those different things. Is it just for correction? Is it for correction when you eat? Is it for only to eat before sports, and so on and so on? So this is, so using the errors, it's not taking away everything else, but it's one piece in the. So when you remember maybe the third or fourth slide I showed, you know, what are the patients have to take into account when calculating their bolus? This is just now another part. And if you do exercise, we all know, I mean, those, like for in my case, my adolescents who do it really seriously, I mean, really like training and being in a team or so, they have to think about and check, you know, what kind of training do we have today? Do we have endurance, or do we have weights or whatever, yeah? Or do I go to a game? You know, a lot of patients, they have, well, during exercise or doing training, I always go low. But if I'm at the competition, I always go high. Well, it's clear, you know, with all the adrenaline coming up, you know, it is totally different. So this is just another piece, but at least you have a way to think about it. That's all we can do and all we can say.
Tá, certo. Tem mais uma pergunta. Eu acho que talvez você tenha respondido ela quase que completa, mas é a Renata de Moraes, e ela pergunta se a sua orientação do uso do protocolo é apenas para períodos pré-prandiais ou em qualquer momento do dia, sem considerar o tempo de ação de insulina. Eu acho que...
Yeah, so I think we in a way we answered it a little bit that it can be pre and postprandial, because when the level is high and it's still rising, for example, it really doesn't matter if you ate before or if you want to eat right now, which you probably shouldn't, but I mean you do anyway, and you have to use it. And if it's 2 hours or 3 hours after your meal and it's still rising, or the other way around, whatever it is, then you want to react. Of course, I mean, if you have say a level of 100 milligrams per deciliter and an arrow down, and it's like 2 or 3 hours after your meal, and you don't want to eat, well, then you don't react anyway. I mean, you wouldn't give insulin anyway. But if you then want to eat, then you probably a snack or whatever, then you probably want to take into account. And if it's going up, then you should take it into account, because if you are like 3 hours after a meal, if you have 250 and the arrow is up, you have to do something.
Ok. Uma outra pergunta, em relação ao uso, né, do freestyle durante procedimentos cirúrgicos. Alguns anestesistas e cirurgiões, às vezes, têm um certo receio do uso do device. Algum fundamento nessa preocupação?
Well, I wouldn't answer to this certain system, because that's always a little bit difficult. But if you just say for CGM, like real-time or intermittent CGM, actually we published a paper earlier this year for intermittent use of CGM, where we actually advise to use CGM, and there are a lot of studies out now during surgery, because it gives the anesthesiologist or the surgeon a much better feeling where the patient is. And there are a lot of studies out now showing that if you have high glucose levels during or after surgery, the outcome is much worse. The same thing is for if you have heart attack or a stroke and so on. So now it is even the question actually to actively use CGM, either brand or either system during surgery. And this is probably also something we have to do as a diabetes community, to teach our fellow doctors how to use it and not to be afraid, or to ask us what to do.
Ótimo, obrigada. Última pergunta, devido ao avançar do horário. Então, a doutora Mônica Gabay pergunta, ela adorou sua aula e adorou também o Easy Wheels, né, que é a ferramenta do freestyle. Você sabe informar se ela vai estar disponível para o Brasil, por exemplo?
Well, I have no information, unfortunately. When I was in Sao Paulo the last time, I know that the Abbott people said, yes, we want to transfer it also to Brazil. But I also know that there is an online version of it where you type in what is the sensitivity and so on, and then it's kind of calculating it. Then you can use a printout or you can take a picture of it or so. And I'm pretty sure that it's out in English on the US webpage, but I'm not sure. But actually, I would just kind of push the Abbott people. I mean, they are doing so much and making so much money now. They can invest a little bit into education, yeah. And it is there. I mean, it is on the German website, and as I think on the US website also. I mean, it's so easy to translate it and then just bring it to Brazil. Yeah?
Ok. Muito obrigada, Dr. Ziegler, por todos os esclarecimentos. Podemos encerrar, então, a aula de hoje.
Muito obrigado, Dr. Ziegler, e muito obrigado a todos mais uma vez. Boa noite para todos. E pode dormir que já são 1h da manhã aí.
Boa noite.
Okay, well, thank you very much for having me, and it was a pleasure again. And I always love to be either in Brazil or with you people from Brazil. So it's always very nice. Thank you very much for having me.
Thank you. Bye-bye.
Thank you, doctor.
Bye-bye.
Bye-bye.